continuation of the lecture yesterday, which I delivered on that is the drugs acting on the GIT. Now the second heading is the antacids. Now antacids are basic substances. They neutralize the gastric acid and increases the gastric pH. Now you know that the acidity takes place due to the higher concentration of the hydrochloric acid in the stomach. So that's why we have to use such drugs which interact or which causes the opposite action or the physiological action on the stomach, that is to increase the pH of the stomach, and that is known as neutralization. And neutralization usually takes place by means of antacids. Now antacids actually they do nothing with the HCl, but they increases the pH of the stomach. So they are the basic substances. So that's why they neutralizes the gastric acid and increases the gastric pH. Now antacid does not increases the acid production. Now just I told you that they are nothing to do with the production of HCl, but just they increases the pH of the stomach. Now the pH of the stomach increases up to 4. That is, this is the sign of increase. There is increase in the pH up to 4 from 0.1 to 1. So they have the acid neutralizing capacity. That is acid neutralizing capacity ANC. What do you mean by ANC? Acid neutralizing capacity of any compound which causes the increase in the pH of the stomach. So how we can define the antacid? The antacids can be defined as the number of milliequivalent of 1N that are able to plot the pH 3.5 in 15 minutes, 3.5 in 15 minutes by a unit dose of antacid preparation. By unit dose means one dose of antacid preparation causes the increase in the pH of the stomach up to 3.5 or the 4, and that is the number of milliequivalent of 1N able to plot the pH. Now again, antacids in empty stomach shows these effects within 30 to 60 minutes. Antacid when used in empty stomach, they show their effect within 30 to 60 minutes. Taking with the meal at 2 to 3 hours. At 2 to 3 hours. Now classification means that taken with the meal. With the meal, if you take the antacid, they requires more time for their action. But in empty stomach, they only requires 30 to 60 minutes. They only requires 30 to 60 minutes. Now classification of this antacid, they are classified into two, that is systemic and non-systemic. Systemic and non-systemic is the classification of antacid. Now systemic antacids are those such as sodium carbonate. They are water soluble, potent neutralizer. 1 gram of sodium carbonate is equal to neutralize 12 milliequivalent of the HCl. So pH increases above 7. Now it is usually comes to the alkaline side. Now disadvantages, because you know every drug, if it is having the advantages, there is certain disadvantages also there, and these disadvantages that is absorbed, they are systemically. Systemic means those drugs which can be absorbed, so they absorb systemically. Large dose will cause the alkalosis. Large dose will cause the alkalosis. So produces carbon dioxide in stomach, distension, carbon dioxide in stomach, distension, discomfort. Now whenever there is production of carbon dioxide, it may also causes, because carbon dioxide is a gas, it may cause the distension. Whenever there is abdominal distension, there is discomfort. The patient feels discomfort, belching, risk of ulcer formation. Ulcer perforation means that there is perforation takes place in the ulcer. So that's why there is risk of ulcer perforation. So acid rebound phenomena may occur. That is present in the stomach due to this antacid, that is, there may be acid rebound phenomena occurs, that is, the acid comes through that connected tube from the mouth to the stomach. Increased sodium load may cause the edema. Now you know that whenever there is sodium ions are present, so increased sodium load. Sodium ion, one sodium absorbs 2 molecules of water, so that's why there is excessive absorption of the water. So increased sodium load may cause the edema. Whenever there is edema, they may cause the cardiac heart failure. They may cause the cardiac heart failure. So that's about the systemic. Now coming to the non-systemic antacids. Non-systemic antacids, they are insoluble, poorly absorbed basic compounds. Poorly absorbed basic compounds. So because they are insoluble, that's why they are poorly absorbed. So in the stomach they form salts with chloride, which reacts with bicarbonate, act as a buffer. Now you know that buffers are those solutions which help to maintain the pH of that media. Which help to maintain the pH of the media. We have studied that buffers according to definition. These are the salts and the acid, or the salts and the acid of the weak acids. So they are known as the buffer. So no acid-base disturbance. So that's why there is no acid-base disturbance takes place. So the drugs which are used as non-systemic antacid, they are magnesium hydroxide. Magnesium hydroxide, I told you that they are less soluble and that is less absorbed. So that's why low water solubility of this magnesium hydroxide. Aqueous suspension can be used, which is known as milk of magnesia. So low concentration of OH ion hydroxyl ion, low alkalinity. When there is low concentration of OH ions, there is low alkalinity. Act quickly with HCl, that is 1 gram reacts with 30 milliequivalent of HCl. 0.4 gram 1 to 5 ml suspension can be used, and 5 ml neutralizes the 12 milliequivalent of HCl. So that is the non-systemic neutralization of the HCl which is produced in the stomach. Now next is the magnesium trisilicate. Magnesium trisilicate, low solubility and reactivity. 1 gram causes the neutralization of 10 milliequivalent of HCl. That is nothing to be described. 5% of administration of magnesium absorbed systemically may cause the problem in the renal insufficiency. Because the route of excretion of this in the kidney, so they may cause the problem in the renal insufficiency. So aluminium hydroxide, also non-systemic antacid, releases, that is, it is aluminium hydroxide having aluminium metal ion, relaxes the smooth muscles of the stomach, causes delayed gastric emptying, so having an astringent effect. So due to this, because this relaxes the smooth muscle, causes delayed gastric emptying, having an astringent effect on the mucosa, which may cause the constipation. So it binds with the phosphate. Now, what's the mechanism of action? That is, this aluminium ions binds with the phosphate ions in the intestine and prevents the absorption of phosphorus. So when there is decreased absorption of phosphorus, it may cause a condition which is known as hypophosphatemia. Hypophosphatemia means decreased phosphorus in the blood. So regular use of this aluminium hydroxide may cause osteomalacia. That is the poor absorption of the minerals, that is phosphorus and calcium. The bones become weak and easily fragile. So calcium carbonate, it is potent, rapidly acting. 1 gram can neutralize 20 milliequivalent of the HCl. Liberate carbon dioxide, that is, again, it is a gas, causes a discomfort and abdominal distension. In this case, calcium carbonate, that is, in this case, calcium carbonate, acid rebound phenomena takes place. Now, yesterday I told you about the acid rebound phenomena in detail. So in this case, calcium carbonate may cause the acid rebound phenomena. Why? The calcium ion, the reason is this: the calcium ions diffuses into the gastric mucosa, and this calcium ion, you know that yesterday in the figure I have explained in detail about the role of calcium ion in the synthesis or formation of HCl, in the synthesis and formation of HCl. So the calcium ions diffuses into the gastric mucosa, causes increase in the HCl production directly by parietal cells and by the releasing of the gastrin, So calcium carbonate may cause the increase in the HCl, so that's why it cannot be used as an antacid proper. So milk algae syndrome, that is, this is the milk algae syndrome. What do you mean by milk algae syndrome? When milk is taken with calcium carbonate or sodium bicarbonate for peptic ulcer, because you know that with most of the patient, they think that we have to take the milk for this to neutralize the acidity in combination with this calcium carbonate and sodium carbonate. It's not. It is contraindicated in this case. When milk is taken with calcium carbonate or sodium carbonate for peptic ulcer, it may cause the syndrome such as headache, anorexia, that is loss of appetite, abdominal discomfort due to the presence of carbon dioxide, abdominal calcium deposition may cause the renal stone. Now the calcium is the most important ion in the formation of the renal stone, that is in the kidney stone, in the form of calcium oxalate, in the form of calcium citrate. These are those compounds which are responsible for the stone formation, right? That is known as renal stone formation. Now, polychloride form gel, that is nothing but the magnesium hydroxide suspension. 100 milligram is present in there. Dried aluminium hydroxide gel, 425 milligram is used. Methyl polyvitrox 125 milligram per 5 ml. Now drug interaction, by increasing the pH and forming the complexes, the non-absorbable, that is non-systemic, antacid decreases the absorption of various drugs, especially tetracycline, iron salts, fluoroquinolones, H2 blockers, that is H2 receptor blockers, diazepam, phenothiazine, indomethacin, and phenytoin and ethambutol. These drugs are not absorbed properly in the presence of this non-systemic antacid. Now the uses, the antacid has a day only used to relieve the pain and acidity. That is, antacid has a days only used to relieve the pain and the acidity. They also used for the dyspepsia. Now dyspepsia means the malabsorption of the food. It is known as dyspepsia, and minor episodes of the heartburn, because minor episodes means when there is acidity, the patient feels the burning of the heart. So that's why these non-systemic antacid may cause the minor episodes of the heartburn. Now how the systemic and non-systemic antacid acts? This is the stomach. Systemic antacid, sodium bicarbonate, non-systemic aluminum hydroxide. So sodium bicarbonate gives the carbon dioxide and sodium ions. So when these drugs or when these are used in a high concentration for a prolonged period of time, they give the excessive amount of the sodium ions. These sodium ions may be responsible for the edema. These sodium ions may be responsible for the cardiac heart failure. So that's why the prolonged use should be avoided. Now the sodium carbonate enters into the blood where there is systemic alkalosis takes place. Now, on the other hand, clear that blood, when the sodium carbonate in the stomach it gives sodium ion, in the blood it gives the systemic alkalosis. Now again the non-systemic aluminium hydroxide. Aluminium hydroxide will enter into the blood only if it requires hydrogen ion, and this is then converted into aluminium hydroxide as such. Instead of 3 hydroxyl group, there is 2 hydroxyl group, and there is formation of water, and that water is entering into the tissues. Now this is about the uses of the systemic and non-systemic antacid. So again, effects of acetylcholine, histamine, prostaglandin E2, and gastric acid secretion. Now this figure I have explained in my last figure, so there is nothing to be explained. So now the drugs are, pyrazine. It blocks the cholinergic receptor, means that acetylcholine secretion. So there is symmetry stimulants of E2, that is prostaglandin. These are all which require there's the calciamides, ATP, cyclic AMP, then calciamides, and there is the conversion of the inactive protein kinase into active protein kinase. The active protein kinase is then active protein kinase activated. Then there is proton pump. Proton pump, that is there is exchange of the cations, sodium, potassium, and hydrogen, potassium and hydrogen. So that is responsible for increase in the gastric acid secretion. Increase in the gastric acid secretion. Now, coming to the mucosal protective agents. Now, mucosal protective agents, these compounds selectively protect the mucosa. Now, you know what is mucosa? Mucosa is nothing but the mucus. This mucus is that component which form a layer of the stomach wall, and that is important because it inhibits the action of HCl on the stomach wall. It inhibits the action of pepsin on the stomach wall. So that's why there is no formation of the bones in the stomach in the presence of the mucosa. So mucosa, either by forming a synthetic covering over the gastric surface or by stimulating the secretion of mucus, means that either there is increase in the formation of mucus or there is forming a synthetic covering. Synthetic covering means the covering on the stomach wall to inhibit, to block the action of HCl and the pepsin on that. Now under this heading, that is mucosal protective agent, first is the sucralfate. Now sucralfate, it's ammonium sucrose sulfate. Chemically it is ammonium sucrose sulfate, known as sucralfate. Now sucralfate selectively binds to the necrotic ulcer tissue. Necrotic means damaged ulcer tissue. It acts as a barrier to HCl and pepsin and causes the healing of the duodenal ulcer. Now there is a barrier, they perform a barrier against the HCl and the pepsin to protect the stomach by forming a layer. That's why they are known as sucralfate. That's why they are known as sucralfate. And causing the healing of duodenal ulcer, it requires an acidic pH for its activation. Now here there is no requirement for the alkalinity. They requires the acidic pH to form the layer, that is the synthetic layer around the stomach wall. So it should not be administered with H2 blockers or antacids. It should not be administered with H2 blockers or antacid, because H2 blockers and antacid decreases the formation of HCl. They decreases the formation of HCl, whereas sucralfate shows their effect in acidic. So when there is blockage of the H2 receptor or the antacid, when they are used or administered, there is no acidic pH in the stomach, and there is no formation of this sucralfate. There is no formation of that synthetic layer or the protective layer of the stomach wall. It should not be administered with this H2 blocker or antacid. It's not absorbed systemically. Now this is the point, that is the sucralfate not absorbed systemically. They are not absorbed systemically. Efficacy is similar to that of cimetidine. Now cimetidine, you know, we have discussed the cimetidine, they are proton pump inhibitors. At 4 weeks, for the 4 weeks utilization, it considered to be the superior, that is the superior who continue to smoke. For the smokers, it is a best preparation to be used. Now in interaction, this is the name of the drug. Now interaction, they interact with various antibiotics, with various compounds such as tetracycline, fluoroquinolones, cimetidine, antacids, decreases the absorption. This component decreases the absorption. Now colloidal bismuth preparation, they forms a coat by binding the gastric and duodenal ulcer tissue. They protect the ulcer from acid and pepsin. Now these are known as colloidal bismuth preparation. So there is nothing to be explained. It is very easy. Now coming to the most important component or the microorganism which is responsible for the formation of the peptic ulcer, that is Anti-Helicobacter Pylori drugs. Now what is Helicobacter Pylori? Yesterday I have told you about Helicobacter pylori. Helicobacter pylori is a gram-negative bacillus or bacteria. It attached to the surface epithelium. It attached itself to the surface epithelium beneath the mucus. Means the Helicobacter pylori, which is gram-negative bacteria, it attached itself beneath the epithelium of the stomach wall, that is the mucous membrane. It is motile even in high viscous mucus. Now again, you know that some of the microorganisms, they are non-motile, some of them they are motile. Means they show their movement here and there. So the Helicobacter pylori is a highly motile bacteria because in the viscous mucus, you know that the viscosity of the mucus is high. So that's why in the viscous mucus it can be motile or it can be moved from under the mucous membrane. Due to this movement of the highly viscous mucus, they adhere with the gastric mucosa by specific adhesion mechanism. Now, by specific adhesion mechanism, what do you mean by this? It means that this Helicobacter pylori, it is gram-negative bacteria. If we see the structure of this Helicobacter pylori, it is spiral in shape. Now, this spiral shape gives the property, the ability to this bacteria to invade itself in the stomach wall and to cause the infection. Clear? Now the bacteria produces the enzyme. Now what is the mechanism of this Helicobacter pylori? How it causes the ulceration? These bacteria produces the enzyme urease. Now you know that urease is the enzyme which converts the urea into ammonia. So which causes the production of ammonia, and protease. Protease is the enzyme which causes the breakdown of the glycoprotein in the gastric mucosa. So in this way, this Helicobacter pylori destroy the mucosal membrane by means of the forming the enzyme urease and protease. Urease causes the increased production of ammonia, and that is dangerous to the mucosal membrane. Similarly, the protease is the enzyme which acts upon the protein of this mucosal membrane, that is glycoprotein, in the gastric mucosa and destroy that gastric mucosa. Now the ammonia maintains a neutral environment around the bacteria. The other important role, that is the ammonia which is formed from the action of the enzyme urease. This ammonia maintains a neutral environment around the bacteria and promote back diffusion of hydrogen ions. Promotes a back diffusion of hydrogen ions means that there is again increase in the production of hydrochloric acid. Whereas proteases causes the damaging of the protective mucosal layer. Just I have explained about this protease. This protease acts upon the glycoprotein. Glycoprotein is a protein which is present in the mucosal membrane. So when protease acts upon glycoprotein, destroy that protein. It destroys that protein, and when the proteins are destroyed, there is destruction in the mucosal membrane. There is destruction in the mucosal membrane, which is a protective layer in the stomach to protect in the stomach from the SCN and the pepsin. Right? Now exposes the underlying epithelial layer of the peptic acid digestion, and it's lead to the inflammation. So these two components, that is urease and protease, are responsible for the inflammation of the mucosal membrane. So when there is Helicobacter pylori, the mucosal membrane is more susceptible for the inflammation. More susceptible for the inflammation. You know the inflammation, and I told you that the sign and symptom of the inflammation is nothing but the redness, the swelling, the pain, and the temperature. So in this case, they inflame the mucosa, is more susceptible to the acid peptide injury and more prone to the peptic ulceration. So more prone means the stomach easily involved to show the ulceration, So it is prone to the peptic ulceration. Now the damaging of the gastric mucosa by Helicobacter pylori results in decrease in the activity of the gastric mucosal barrier. Now you know what do you mean by barrier? Barrier means the hurdle. So gastric mucosal barrier is that barrier which is present between the stomach wall or the membrane and the stomach itself. That is nothing but the mucosal membrane. That is nothing but the mucosal membrane. So the damaging of the gastric mucosa by Helicobacter pylori results decrease in the activity of the gastric mucosal barrier. When there is decrease in the activity of gastric mucosal barrier, automatically there is opening of the mucosal membrane for the action of the SCN and the pepsin, and which are responsible for the peptic ulceration. So which permit back diffusion of hydrogen ion, resulting further tissue injury, causes the local protective defect. It is known as local protective defect. Now, to treat this disorder by the Helicobacter pylori, there are certain drugs which are known as anti-Helicobacter pylori therapy. Anti-Helicobacter pylori therapy is now recommended in all ulcer patients who shows the positive test for Helicobacter pylori. Helicobacter pylori. Now these are the antimicrobial drugs. They have been found clinically effective. They are amoxicillin, clarithromycin, tetracycline, and metronidazole. Amoxicillin, clarithromycin, tetracycline, and metronidazole. These are the antibiotics or antimicrobial drugs which can be used against the Helicobacter pylori to kill it or to incubate the growth of this Helicobacter pylori, right? Now again, it has been observed by single drug therapy, resistance has been developed. So a number of 2 days and 3 days regimes, that is 1 or 2 weeks duration, is required for the complete treatment of this Helicobacter pylori. That is the ulceration which takes place due to this Helicobacter pylori. So there is a number of 2 days and 3 days regimes of 1 or 2 weeks duration have been reported 60 to 96%, that is they indicate the action of Helicobacter pylori. So the 2 weeks regimes, those drugs which can be used for 2 weeks, they are amoxicillin, their concentration, tinidazole, and omeprazole. So combination of these 3 drugs, amoxicillin, tinidazole, and omeprazole, then the combination of these 3 drugs given to the patient for 2 weeks, there is complete eradication of the Helicobacter pylori action. Now second is the clarithromycin. Clarithromycin in combination with amoxicillin and omeprazole, amoxicillin, metronidazole, and pinacidine. This is again third combination. These drugs can be used for 2 weeks for the eradication of the Helicobacter pylori in the stomach. So these drugs usually having severe side effects. Though we can use this drug, but again they are having severe other adverse effects. So the United States Federation of Drug the Alliance for the FDA so approved the regimes. US Federation of Drug Authority approved the regime as lansoprazole, amoxicillin, clarithromycin, all given twice daily for 2 weeks. It has achieved 86 to 92% eradication rate. Now, Helibact, that is amoxicillin. These are the amoxicillin. These are the name of the drugs which can be used in case of Helicobacter pylori. Now, Pylomox, lansoprazole, amoxicillin, and tinidazole. These are the drugs which can be in combination known as Polymox, and this Polymox can be used for the treatment of Helicobacter pylori infected. So that's all for today's lecture. Hope that you will be able to follow that. Again, I'm saying to you, if you are having any problem, if you are having any difficulty in this lecture, you can ask to me under the group of second prof. Now please be careful about this point that the question should be related to your text, to your subject. Irrelevant questions are not allowed on that group. So if you feel any problem, any difficulty under the lectures which I have delivered yesterday and today, you can ask to me by raising your question or by conveying your question on that group, under that group. Now, second request is this, that for attendance you should give, particularly I'm saying to the CR and GR of this second prof, they are responsible to take the attendance of the students and then share it on this page, that is the attendance page on the YouTube. So that's why your attendance should be counted. So that's all for today's. Next time we will discuss the other topic, right? Okay, thank you and Allah Hafiz.